The floor is now yours.
What is the plan for recruitment for nurses and doctors to do with mental health?
Is that for Maria?
Yeah.
Well, I'm sure there might be others who want to comment. So I'm actually doing some work with Health Education England at the moment, because if we look into the future and the population increases and people living longer and perhaps, increasing mental health need in particular, we're probably not going to have enough doctors and nurses if we just model in a straight line. So what we are doing is making sure that the numbers of the new therapies that we've talked about in the 5-year forward view, that we're training a whole raft of new roles really coming through. So things like primary care practitioners, people who are supporting psychological well-being, all these other things. Often if I talk to patients, they don't say, I think I got better because of the number of letters after someone's name.
Absolutely.
It's about their empathy, their skills to unlock and unblock, to really understand the needs and the social situation. And I think some of the plans for recruiting those sorts of other supporting staff will, I hope, bridge the gap between the numbers of doctors and nurses. There are other big challenges around keeping nurses and doctors working in the profession, because it's very hard work out there at the moment. That's for bigger people than me to sort out. But, how we absolutely incentivise, make life as good as we can. One of the initiatives that we're looking at the moment is how we provide emotional resilience support for staff. And actually that makes a real difference to saying, I might stay another year in this very hard job because I feel a bit more supported.
Absolutely. We've got another question at the back.
I myself have ADHD, and I went to my GP over a year ago. I asked to be diagnosed. I was sent to Cllr hospital. For a year and a half I've been waiting to diagnose with ADHD. And I do know that there are many adults like me who they have ADHD and they are unable to diagnose, because in Cllr hospital there's only one doctor, one after Wednesday afternoon. So my question is, it's nice while we're here, but if me as a counsellor, I cannot get an access to any service for a year and a half for a simple diagnosis, imagine what else in my community is going on. And why we cannot have one more doctors to deal with patients with mental health issues in Barnet, which is 360,000 people?
I suppose I can't answer for Barnet, but I can answer for ADHD at national level. I've been working in mental health services for 35 years. And every time I've got a management job, clinical director, medical director, other kind of roles, I have tried really hard to say, I've got a cohort of consultants. They need, if one of them had a half a day a week to link in with the specialised services to develop that competency and to be supervised, we would actually be able to spread the knowledge much more. And I have to say, I think if we could change the model of specialised services, we now have a digital world. There is nothing to prevent, if you have an ADHD specialist at one of our big tertiary teaching organisation centres, to actually start making that knowledge more transferable into the local populations. We don't have a national plan to train, as far as I know, to train more people in ADHD. We have to use the people we've got in a kind of a very different way. So I think my question to you might be to ask, for your patch, how does your patch compare, your CCG compare to other we can give you the information of how your patch compares to 9 other comparable areas in terms of the rates of people with ADHD, what kind of access is there, what kind of solutions are there in other places. Because we know that at the end of the day, only 1/3 of all the people that need mental health treatment are getting access to it. And we know that the budget's shrinking. So the question is, how do we get the budget increased? We know that we are now, as a country, dropping below the European average, almost, for any affluent country in the proportion of spend on healthcare. So what solutions can we have? And I would throw that back to you as a local councillor, part of Oversight and Scrutiny Committee.
In my case, I'm the opposition councillor, but I do have spoken with the leader of the council, Richard Cornelius, and I was told that there's nothing we can do because mental health, it doesn't exist in Barnet. That's why I was surprised that you said Barnet, Enfield and Haringey, because we never see you in our council. And it's not personal to you, it's just as an organisation. I personally, as a council, which I'm dealing actually at the moment with a case in Hendon, I don't see you. I have tried to email and no response, nothing. And that's why it was my question. Yeah.
No, I think it's a really good question. But
I'll be really happy to pick this up with you. I don't want to go into individual cases if you don't mind, but I think one of the things I would hope for out of these sustainability and transformation plans is that they have 3 gaps to address: health and well-being, care quality, and the financial gap. We absolutely know that in certain parts of the country, much less money is going into mental health, and much fewer services, mental health services, are being commissioned than in other places. I will say no more, but I do hope that the STP will be able to equalise some of those allocations. Happy to talk to you afterwards.
Okay, we've got a couple of questions at the back. I think we're going to take the gentleman in the grey suit and then we'll come to you, the young lady in the
Nicholas Hurst, Governor, North East London Foundation Trust. Excuse me. 2 or 3 points. Luciano referred to integration. In our area, in my experience, we have greater problems between West Africans and Caribbeans than I do between black and white. And that is something that really concerns me. We can arrange something in our community, but it can't be run by 2 Jamaican ladies and a Ghanaian, because by the end of the evening, we will have the food on the floor. That's just one example of why integration is not just to do with black and white in your community. We certainly, Jacqui talked about talking therapies, and in Barking and Dagenham, where we have got one of the greater, the 5th, I think it is, poorest borough in the country, and we have problems with mental health there, but we've greatly invested in talking therapies, and that has made a tremendous difference. The other point which was made by Maria, where we're talking about BME communities and our staff. Now, in Nelft, last year, we won the nationwide BME competition for the best E&D, equality and diversity, treatment of our staff. That was nationwide against. We were shortlisted with John Lewis's and Tesco, and we won it. And this year, we've been shortlisted again. So it can be done if you try hard. I promise you that.
And can I pick up on the first question that was raised when looking at possible conflicts between the BME community themselves? And I will draw upon the experience I had earlier today in Dr. Ndegwa's workshop, and one of the questions that were posed was, how do you deliver a service to a group that is very diverse and it's going to be the same for everyone? And one of the other delegates in the room turned around and said, we all have a responsibility to understand that we live in a multicultural, multifaceted community, and we all have a responsibility to work towards making that an equal playing field where we can all communicate successfully. That happens more successfully than in others, but I think this type of environment where we are bringing together everybody, all people from all backgrounds, can show that we can work together irrespective of your cultural group, and even in a particular ethnic group where there are some divisions, we can still come together and work successfully to come up with solutions. So I'd say to you, sir, have that street party again and we'll get the whole community together. Does anyone want to pick up on the other 2 points that the gentleman made?
Well, I might just, I've already taken the Chief Executive of NELF's offer up to come over, and we're meeting with your Diversity Forum. We're already doing some work with Wellington and others at your trust. Yeah. Well, you know, we want to learn.
Okay, so we've got a question at the back and a question at the front, but Jacqui would like to jump in first.
Yeah, I just want to say something about psychological therapies and access to psychological. The theme here is about ending discrimination in mental health and about the differential outcomes for people from black and minority ethnic communities. Within Lambeth, one of the presentations that the Black Wellbeing Partnership looked at, a piece of work that we looked at, was about the differential outcomes for people from African and Black Caribbean communities who use the IAPT services. So IAPT recovery rates were different from all the rest of the communities. In fact, they didn't recover. Even though those ones that stayed and completed the sessions didn't have the recovery rates like their equivalent peers, and that was particularly pronounced around African and Black Caribbean men. And one of the reasons, so they're going to do further work around that, because that's an issue, obviously. It might be to do with the treatment model, because we know also that CBT doesn't work for everybody, which is a sort of regular, I don't know where anyway, we won't go down that road there. But one size does not fit all. How can it fit everybody? I'm a size 8 shoe. I don't fit into a size 3 shoe. I don't fit into a size 10 shoe. I fit into a size 8 shoe. I can only walk in that. The point's made. But one of the issues around that is that the issues that come up for those men are particularly different. And one of the things that keeps coming up is like post-traumatic stress syndrome. So when you look at that, and then you look at what I'm talking about, all these multiple stressors that the black communities are facing, then you have a deeper understanding. Then you have to look at, well, how do I respond to that more appropriately? So once again, we have to have a better analysis of what the data is sort of saying to us.
Also, please. I think one of the sort of like things around diversity and sort of like specific cultural services are just not existing. It's more the funding in relation to it is dying off, or has been dying off for a while. But it is about, in a sense, diversity within the workforce and getting that representation across multiple cultures within the workforce. And I think if we look at the snow-capped mountain approach that you talked about, we in some cases when we say take it away, that an intervention needs to be done by a highly specialist person. So we need to actually bring down, in a sense, more cultural resilience and have people from their own culture and communities actually delivering services. And then you'll get a better reflection of people actually giving you advice, giving you support and giving you interventions. So, I mean, it's quite interesting to see that with mental health, it's still strongly dominated by psychiatrists and nurses. And if you look at, say, the drugs and substance misuse side, it was as well strongly dominated by psychiatrists and nurses. And then there was a paradigm shift to say, actually, we need those specialist services, but what we really need is people who are actually close to those substance misusers to deliver services. Not current drug users, maybe, but people who actually have lived experience of the problems, actually delivering the front-end services and then using the resource of specialist carers thereafter. So I think we could possibly do more with that within the mental health field and actually whilst using our specialist colleagues at their top end and the high end of actual need.
Absolutely, absolutely. Okay, so we do have two questions. We're going to go to the young lady at the back and then we'll come at the front.
Hello, I'm Rita from Dementia Partners. We've got approximately 100 service users who go into different settings and speak to service users, and the feedback is that if they go in regularly and the specific details are taken from individuals using the services and fixed as you go, that would be a preferred approach. So the request is that service user involvement is maximised, it's more frequent, individuals reassured that it's transparent and that they can have confidence that they are being listened to and will be listened to at regular intervals, and that fix as you go approach is a commitment. For example, one of our experts by experience said they emailed 100 emails when they were in services and didn't get a reply. So if that person is not interviewed and if that person doesn't discuss their experiences and highlight the problem to you, you're not going to know about those problems.
Absolutely. Thank you so much. Just to follow up on that point, though, some work that Penrose does in Luton, for example, it is about developing that capital within the individual to bring their experience and levels of expertise to others who might be going through a similar pathway. And we're starting to see some really positive results in individuals being empowered who have gone through the pathway and emerging fully confident and feeling that they are contributing effectively. But on the flip side, it's about the individuals who's receiving that type of support and attention from somebody who actually knows what they've been through. And we are starting to see some real dividends being paid in recovery and moving forward in Luton, and we are now moving that into our other areas in Lambeth, Lewisham and Southwark. So that is an absolute must. Yes?
I've heard a lot today about the problems and the commitment to change, but I haven't heard much about the operational side.
Sure.
So for delegates here who may want to be inspired to go back and actually put something into effect, you know, I'm not sure they have the operational know-how to affect that. So it would be helpful. I know you've got a series of talks, and that would be great for another day.
Absolutely. As we mentioned earlier, this isn't just the start of the journey. At the front, we've got two.
My question is for Leo. Leo, what impact does substance misuse have on the service that you provide?
Oh, well, Equinox provide a number of services, so it's mental health and substance misuse services. But of course, there's always an interaction between the two. So in terms of substance misuse, it may precipitate or actually hide or guard, or people may self-medicate their mental health issues through substances. And then they go into a sort of like perhaps a mental health service and they say, okay, well, you're using heroin or you're using alcohol, you're not appropriate for us. Or you get the reverse situation where someone has maybe mental health issues, a substance misuse issue, and they go to a substance misuse service and say, sorry, that's a mental health issue. So the interaction between the two can be quite complex, and actually getting the right service can be quite difficult. So it kind of does depend on sort of like the presenting needs. And so it's a really tough question because it's so diverse and broad and wide. But in terms of the impacts, I think sort of like what we need to do now is actually get people to accept more, but these are complex needs and they work together. Sort of like, and to training for people in substance use or more on the mental health side, and so many people on the mental health services getting more training on the substance misuse side.
Can I just make
a lot of times, yes, they can do. And could we just allow...
Can I just make a quick comment as well? Because I think the thing about substance misuse, I think you're really right to ask it as a question, is that I think what has not been understood until fairly recently, when people are looking at the causes of why do people come to your local physical health hospital, why are people coming, getting admitted, it's not really been understood the role that substance, and I hate the word substance misuse. In America, they now call it behavioural health, the word the behavioural health difficulties have for people. So
it means the same thing.
Yeah, exactly. But I think sometimes language is important, because I think one of the reasons people don't and have taken a lot of money out of substance misuse services is because there's people who cannot get their heads around why somebody might do it and why they can't just stop. And I think that's really stopped people funding. So to give you an example, I think where people are beginning to listen is that in the liver units in acute hospitals, 70% of the people who go there all the time, get the transplants, etc., have an untreated alcohol problem has led to it. In the intensive care unit, in a physical health hospital, if you think, why does somebody need to be in intensive care? And it's usually because they've had a really bad car accident or a domestic accident or a road traffic accident of some sort, which at the root of which is often alcohol. Suicide in this country, 50% of people where tragically there is a suicide goes on, somewhere either around the time it's happening, in despair often. Alcohol sometimes, it's just the trigger that can kind of lead to people happening. A&E, fracture clinics. Why do people get fractures? Why do they get a broken jaw? domestic violence. What's behind a lot of domestic violence? It's the substances. So I think there's beginning to be an understanding about, let's not just say somebody came in with a fracture. Let's look at what was happening. Were they drinking at the time? And what led them to be drinking? Was it untreated depression? Was it terrible financial stress? What was behind it? And until we actually start thinking, really understanding, as Jacqui says, the roots of things, I don't think we'll tackle it as much as we can.
We're looking at the pathways of their journey.
Absolutely.
Yeah.
Absolutely.
Okay, so this gentleman's been waiting for a while, then I'll come to you, sir, and then we'll go over to the corner.
My question's actually quite similar, but to Jacqui. You've talked about talking therapies as a way of communicating and getting out of that situation. If we looked at prevention is better than cure, would we not say then the BME community, could we not set up community sessions where they can just talk and get the things out? Because it could be the issue that obviously leads to the BME community. We did a video. I deal with enterprise for young people and look at Kofi Opon. And I work with Sonia, who has Find a Balance, to look at getting people into jobs. One of the big things that came up when we did a video on Saturday was obviously lots of the BME community do not talk to each other about mental health. Yeah. We have much more younger people bringing up children, in a sense, so kids bringing up kids.
Yes.
Is then the solution not to set up a situation where the social impact of being able to talk within families would potentially prevent much more of that situation, if you're already saying that talking therapies is the key, which Sonia talks about quite a bit as well as the part.
I think so. I think that's absolutely accurate, because if we're looking at closing the tap, moving the system is orientated to locking people up, and we need to move the system to where it's more a preventive, early intervention kind of arena. But part of it is about being able to reduce some of the stigma and discrimination around mental health issues within our communities, and some of it is about learning how to better communicate. But we need to find a range of methods to do that. Some of it is talking therapists, some of it is through art. There's a whole area, the untapped area. I was privileged to be at the International Arts and Film Festival in Glasgow on Monday or Tuesday, and it was an international film festival where there was about 1,600 submissions from all over the world, looking at presenting different ways around the issue around mental health. And there was 10 awards: documentary, short documentary, long documentary, cartoon, whatever. And if you see the way that people are expressing issues around mental health challenges, the pathways into crisis around mental health or whatever, you realise there's a whole wealth of ways that we can talk about mental health, that we can develop ways to better communicate about that within our communities, other than some of the very restricted, narrow set of ways that we're currently doing. So very much, I think that there's a window of opportunity that we need to embrace. And if we look even further at the fact that in London, actually for this particular community, that the levels of detention in, say, like for secure services, far outweigh any other parts of the country compared to the level of proportion of those communities in the population, then we have to realise we've got to do something very urgently about this. So I would like to actually ask you to come and help me to do something about that within the London Thrive sort of project that we're working on, if you may.
Okay, I do have a question here, but I know that Geraldine would like to just add to the discussion.
Incredibly quickly, I don't know, did Norman mention it this morning, but in the West Midlands, or the West Midlands Commission, we've kind of got the money to get 5,500 more people back into employment, because we've got the money put forward working with the DWP and government to get IPS as individual placement support to help people get in, and it's going to be done in 3 ways. One is prioritising people who already have severe mental ill health and at the minute have a 4% chance, working with people in primary care to see can we actually select more people in primary care to kind of help, and then there will be some working with kind of communities. So that might be an interesting scheme as well, to get back to here. How's it going? Yeah.
Now, before we move over to the question in the corner, I've got another point.
A small addition to Geraldine's point, which is the 5-year forward view does commit to doubling access to the individual placement scheme across the country. The challenge, which will help people to both find and then retain employment, the challenge will be to make sure it's targeted in the right areas. And that is something that counsellors, that you know, we can all do and we must all do. That is the challenge, to really track where these new schemes are going to go and what the outcomes are.
I think, I think that, oh no, let me shut up.
Thanks, Jacqui. No, this gentleman's been waiting for quite some time.
Hello. Basically, what my question is, you know, regarding medication for service users, you know, when you've been on medication for a long time, you shorten your life expectancy. You don't live this long. In danger of having heart disease, diabetes, all sorts of complications. And you know, when certain people like doctors, consultants, and they go through, well, you know, you go through have bush medication for life, or you go have bush medication for a long period, spell. You know, they don't give you they can't give you a time frame where you can stop using it. There's no, you know, you know what it does to the human body. It's a side effect. It might help. It might help. In some cases, the diagnosis to be controlled, but the side effects is far more dangerous, than actually having that medication for so long. So, what's the alternative to that? Because it's shortening your life and ruining your life expectancy.
I mean, I'll pick up on that because in Penrose, we obviously work in with a range of local authorities, CCGs, and in Lambeth in particular, in one of our forensic mental health services, we are working with the psychiatrists to look at how we can reduce medication by a staged approach and monitor how the individual then is able to function. And where we are starting to see some really positive results. In fact, we've had 2 of our clients who have come off medication altogether, but that's not just in the silo of reducing medication, it's about giving alternative support mechanisms, and we've had many of that discussed today. For example, as I mentioned in Luton, it's about getting people active, getting people involved in things like gardening, horticulture. You know, we've heard things like cycling projects, we've heard physical activities where you can hopefully start bringing some parity to the drugs you're taking, which can cause you to put on weight, reducing that, getting physically active again and starting to reclaim your life. It's a slow process, and it's about working with quite open-minded psychiatrists who are willing to take, not the risk, it's a managed risk, but the opportunity to make that reduction and bring people away from the pharmacological model.
Yeah, I mean, that's also good and dandy, but the reality is too slow. So, like some people that I know are like on the highest dose of the medication. You make them diabetic, you make them all sorts of complications. They don't have confidence like they used to because they feel like they don't feel the physically attractive, the way how they would want to the opposite sex, to the mate, to the peers, to the family, to everyone. That's another downside. That's just one of them. There's loads of them.
Absolutely.
I like for somebody to be told that, somebody to be told, they can't reduce your medication because you're well on it, it's working for you, and, so you got to stick to it. That's it. If you don't take it, then you have to go back into the hospital, things like that, locked up. And then, so, like, I forgot now. Like, I forgot.
No, you've articulated your point very clearly, and I don't think anybody in the room would be in any doubts about what you're trying to say. And like I've said, we are trying to make strides in changing that methodology. But in addition to that, I'm sure my esteemed colleagues on the panel have got other examples where people are trying to move away from the over-reliance on the pharmacological model, because that has been proven not to be a cure. It's just a maintaining status which allows people to be content maintained. So, you know, we are moving and working hard towards making some of those changes.
Thank you.
I mean, I was just going to say that my line with, because I think medication is a really, you know, we can't just take a blood test these days and say this medication works for this person at this dose. It is about a dialogue. It is about a really, when you talk about personalised care, this is probably one of the greatest forms. And my line with my service users has always been, take a look at your hand. Medication is the little finger. Sometimes, if you haven't got a little finger, you might just completely fall over. So to start with, sometimes the medication is really good to help people feel calmer, have a decent night's sleep, in order to be able to think about, okay, let me talk through what's going on for me. Let me work out the causes. Let me work out my triggers. And then, having done those, how do I then act? What else do I need in my life? I mean, I think that was the most beautiful example from our chair of what exactly can you put in your life in order to be able to go forward. And if you get in a wobble, diagnostic term, a wobble, if you're going on a wobble, where do you get help quickly? And the thing I just want to flag up with everybody is, at the moment, in all the crisis services, so 111, street triage, crisis home treatment teams, liaison teams, A&E, 1/3 minimum of all the people who come are coming repeatedly. They're having repeat episodes. So that something is not right in the nation of the care plans we've got. And I would really plead with people. I have begged people, I can't tell you many times, say, if anybody has a care plan that works for them, and most of my service users had, then can you help teach people what a really good care plan looks like that doesn't completely rely on the little finger?
Thank you.
Okay, we've got a question in the corner, then I'll move to the question in the back.
Nobody's mentioned people from ethnic minorities who don't speak English, and I wonder what's the... it's a huge problem for us locally, and I'm sure for lots of other people. And I was wondering if there's any national voice about funding for translation and advocacy services. That's my question. And my suggestion is perhaps we need a BME Concordat to actually start to work nationally.
Jacqui, would you like to pick that one up?
That's such a great idea. Yeah. I don't know where the work is that actually is being done around people who don't speak English as a first language. Actually, I don't know. And I myself haven't had that dialogue about that. So that's something I will take away and see. But actually, how do we robustly, at a very national level, address some of the challenges that we're facing in relation to many of the issues that have been articulated here? And maybe it might be a concordat on the matter, who knows? That could be quite a good idea. I was just listening to the gentleman here and thinking, my God, it's just so personal.
Yeah.
It's just so personal. I can't tell you how personal your experience is. And I'm really grateful that you're in the room and speaking with us today.
Okay, I'm going to move it on swiftly. I've got a question in the middle row.
Mine isn't really a question, it's a comment that looking forward, assuming that some progress is made, I hope that there will be an external perspective taken to explain the huge steps that this area of the community is taking to explain to society as a whole what is being undertaken, and that we as a society need to ensure what our goals for living with each other are, and that as a society we are prepared to take on the reintegration and the rehabilitation of people who have experienced mental unwellness. And this sort of discussion needs to always remember to tell the rest of the world about it, not to keep it to oneself.
Yes.
Absolutely.
Well said.
Unfortunately, this is being broadcast to a very wider audience, and it will be shared more widely. And I think the more type of events we have like this, and not just like this, but where it builds on this, it then starts looking at the solutions and sharing some of the operational practices and methodologies that many of us in the room have implemented in our own local services and within our own provision. It's about sharing that now, and it's about spreading the word so that we can make some real step changes. Okay, so we've got another question at the back.
Hi, this question's not really from me. It came out from a group.
Can you tell us who you are, please, and where you're from?
Sorry. Vanessa Deutsch, SUI Manager for Social Interest Group Equinox and Penrose.
Thank you.
So it came out from a group that I did a few weeks back, and I was trying to think in my head, how do I actually formulate this question, because it's quite complicated. But from that particular group, it was looking at that the BAME community is bigger than the Afro-Caribbean community. And one of the comments that people were looking at was a recognition, is there a recognition in mental health that there is an increasing rise of a refugee community coming from not only Syria but also from Africa? And it kind of ties in partly to what you were saying around English being a second language for a lot of people. But the recognition, is this being recognised in mental health services? Because people are coming into contact. They are coming into contact with police, drop-in centres, but more so they're being picked up by smaller local communities or community services, which might not be attached to anything statutory. And what type of support is there? Because we are looking at not only adults, but we're looking at children as well, that are coming into that group and are coming into schools, but don't necessarily have the support that their fellow classmates have. So looking at the isolation, but the recognition within services, how are these individuals being supported, what funding is there to move that support forward if it's not actually in place at the moment?
I think the panel are already aware, they weren't aware of particular facilities to support that.
No, I mean, to be honest, I think there'll be a number of voluntary sector organisations who have been working in this field for a long time. We're certainly seeing a rise in PTSD needs in the community generally in relation to that. I think, though, that at the moment it's probably fair to say that these needs are being met out of mainstream funding rather than having extra investment in these, really highly needy populations. And that's absolutely something that, particularly where there are large cohorts or groups of communities coming in. We have large communities in my own boroughs that we really need to start significantly targeting those groups.
Okay, we've had an amazing opportunity today. I personally am humbled by not only the amount of enthusiasm, information, support, questions, knowledge, ideas and solutions that we've managed to generate today. I've heard at least 10 different projects that are working towards making a change within the subject matter that we're talking about. I also want to thank you guys for attending today and for the contribution that you've made for making this an opportunity for us to do what we said right at the beginning, start moving this dialogue forward. Myself and Jacqui have had many a conversation about we need to stop talking about this now and start moving it forward. And I think you guys have really supported that agenda. So please give yourselves a big round of applause.